Welcome back. Today we'll be going through the anatomy of the peritoneum. So the peritoneum is a thin serous membrane, and it basically encloses all of the internal organs, and it secretes the peritoneal fluid, which allows the free movement between the organs and the viscera, which is necessary because during digestion the stomach needs room to move in order to grind the food mechanically. And that's the liver. I'm sorry, here's the stomach. And the bowels will have to contract and push the food through in order for it to reach like the rectum, of course. And the peritoneal fluid is made out of water, proteins, electrolytes, and some white blood cells. And there's a little bit more in women than in men. And in men, it's going to be a closed structure. And in females, it's going to be open to the outside cavity. It's bounded by the diaphragm up top and the plane that passes through the linea terminalis along the abdominal wall. So you would see it kind of like coming in a corona section, just kind of hitting the abdominal wall on this end, and then the spinal cord on this end. The extraperitoneal tissue will separate the parietal peritoneum from the fascial walls of both the abdominal and the pelvic walls. It's better developed in the lower abdominal wall and the pelvis. And in the retroperitoneal space, so behind the peritoneal space, are going to be the organs along with the aorta and the internal vena cava. The greater sac will be from the diaphragm down into the pelvis, and then the lesser sac is kind of held behind the stomach, and both will communicate through the Winslow foramen or the epiploic foramen. And then in front of the stomach, is going to be the supracolic compartment. So here's the lesser sac behind the stomach, here's the greater sac. Okay, so there's a couple components of the greater sac. The supramesocolic colic will contain the liver and the stomach, and then the inframesocolic compartment will contain the intestines. The Jackson's membrane is the vascular part, and it passes over the ascending colon. And the intraperitoneal organs are going to be covered with the peritoneum, and then the retroperitoneal are going to be somewhat covered. The peritoneal ligament is going to be a two-layered fold, and it connects the solid viscera to the abdomen wall. And there's a couple different ones. There's the falciform ligament, the phrenic colic, and the coronal ligament. And here's the falciform ligament. See, it connects the liver to the anterior wall. The omenta are going to be two-layered folds of peritoneum, and that connects the stomach to the other organs. And the lesser omentum will kind of like suspend the lesser curve to the ligament, so it's going to kind of like hold the omenta up. And then there's another big one that connects the stomach to the spleen, which is the gastrosplenic omentum. So here's the peritoneum, as I say. This is going to be like the greater sac. Here's the intraperitoneal organs, so they're inside the sac. Mesentery. Okay, so it's all of this. This is the Jackson's membrane. Look how like vascularized it is. The greater omentum is going to connect the greater curve of the stomach to the transverse colon. So like right here, and it's very reactive. So it has a really neat property. It can promote new vessel formation to whatever it's formed to, and it helps a lot with infections and in injuries, because inflammatory exudate or pus will cause the omentum to adhere and like wrap around the infected part. So if the transverse colon, let's say you have a nick on it and it's starting to get for lack of a better word, abcessy, the omentum will wrap around that area and kind of like seal it off, and in the meantime promote new vessels to like to bring more white blood cells to the site of infection. So it's also used in surgery to secure the wound closures or anastomosis or fill dead space. So any kind of like surgical removal of parts of the colon, it can be used to like kind of like patch that hole up. However, if it's not removed properly during these surgeries, like you have to stretch it up. It just can't be like, you know, wadded up in a little fossa, because it will undergo torsion and that will cause the peritonitis. And this is also where abdominal fat is generally stored in the obese males. Problematic because the fat can it can mess with the ability to adhere to the organs and also compress the vessels going through it. Okay, so there's a lot of mesenteries, and basically a mesentery is a two-layered fold of the peritoneum, and it connects the intestines to the posterior abdominal wall. And there is going to be like the stomach, here's the transverse colon, sigmoid mesocolon. The ones that have clinical significance is the splenic peritoneum, and it's attached very strongly to the splenic capsule. So in major trauma, it can you can pull too strongly onto the peritoneum, and that will cause the splenic capsule to tear, because the capsule is fragile while the peritoneum is stronger. So as you recall, the splenic artery and veins are major vessels in that area, and it can cause like a very, very serious hemorrhage. So same goes with the frontocollic ligament. So and the area where where the diaphragm is attached to the stomach is also very strong, and it is very well vascularized. The walls of the omentum bursa will be the anterior posterior wall of the stomach, the lesser omentum, and the gastrocolic ligament. Splenic recess is right behind it, along with the pancreas, the left kidney, the adrenal gland, the internal vena cava, and the aorta. So this is a pretty important area. It's high risk. Below it is the transverse mesocolon. Above it is the caudate lobe of the liver. On the left is the lienal recess, and on the right is the foramen epiploicum. So the foramen epiploicum will convey the hepatoduodenal ligament, and that contains the hepatic artery, the portal vein, and the common bile duct. The lienal recess is pretty empty, but in bad cases, the lesser sac can herniate through it, and that's not good because it can undergo torsion and then cause peritonitis. So this is a pretty important area in the body. So Winslow foramen, it kind of goes behind, as you can see, the hepatoduodenal ligament. It's a potential site for internal hernia, but more importantly, it's a good landmark to find the hepatoduodenal ligament. So in case you need to do like a cholecystectomy, or there's like a bile duct obstruction and you need to remove a gallstone that has like blocked it, this is a good area to find, because right, like if you stick your finger through the foramen of Winslow, right in front of it is going to be the hepatoduodenal ligament. So, and from there it's pretty easy to find the common bile duct, because it goes like DVA, so duct, vein, artery. That neat little maneuver is called the Pringle maneuver. So there's the duodenal recess, and that is going to have several different components, along with the caecil recess. There's also the intersigmoid recess, which is going to be the inverted root of the sigmoid, so it's like a tiny little upside down V. These recesses are just important to know because this is generally where abscesses and malignancies occur. In males, the bladder distends and the overlying peritoneum is lifted when the abdominal walls contract, and then the bladder can come into direct contact with the abdominal wall, and that's important because any kind of suprapubic puncture can go right through the bladder without going through the pelvic peritoneum. kind of like a double-edged sword, because if you pierce the peritoneum, you can cause peritonitis, which is really life-threatening, but neither do you really want to have your bladder pierced either, so just don't get stabbed there. Okay, hernias, protrusion. Subphrenic spaces are going to be they're really like areas where the peritoneal fluid is able to flow. There's two right and left anterior subphrenic spaces, and that lies between the diaphragm and the liver. And then the right posterior subphrenic space is going to lie between the right lobe of the liver, the right kidney, and the right colic flexure. And then the right extraperitoneal space will lie between the layers of the coronary ligament, and that is also between the liver and the diaphragm. So these spaces are just like really where the peritoneal fluid flows, and it kind of keeps all the organs from touching each other and like reducing the amount of friction. Morrison's pouch is going to separate the liver from the right kidney, and it leads into the Winslow foramen. So this is more like a clinical landmark. You can see here's the Morrison's pouch, here's the kidney, and you can follow it to the liver. Okay, so the paracolic gutter has a kind of connection with the subphrenic spaces, and there's like two right and left, and these are where the routes of infection occurs, because infection can spread into the pelvis down the left paracolic gutter, or an infection from the appendix can rise and go all the way up to the liver, and the infracolic space that goes down and can affect the ovaries along with the left infracolic spaces. And like these kind of go down ways, but the paracolic gutters can convey the infection like both up, like towards the head, and down towards the uterus and the ovaries and the penis and prostate. Okay, so the mesentery sinuses will lie between the root of the mesentery ascending colon along with the transverse colon and the transverse mesocolon, so like around this area, and they really widen when it's continuous with the cavity of the pelvis, as you can see here. And the umbilical cords will have the umbilical artery and veins that run on it. The urachus is going to be the most medial, that's the medial fold, and of course that's a remnant of the urachal ligament in embryology. And then the parietal peritoneal will kind of like cover all of it, and then it reflects over the the vein and the artery on the lateral umbilical fold. So the pelvic peritoneum in males is going to be the retrovesical pouch, and in females is going to be the Douglas pouch or the vesicouterine pouch, and that will contain both the bladder and the uterus. While for the males, it's only that like tiny little pouch in the back. It doesn't really contain anything. So the parietal peritoneal is pretty sensitive to pain. It's very like well localized, along with temperature, touch, and pressure. It's innervated by the lower 6 thoracic nerves, along with the first lumbar, and the phrenic and the obturator nerves, so well innervated. When the parietal peritoneum is irritated, the muscles will contract and causes a guarding, and that will make the abdominal wall rigid. So when you're palpating the abdomen for any kind of organomegaly and the patient is like clenching, that's what we call guarding. The visceral peritoneum is sensitive to only the stretch, and it's only innervated by the autonomic afferent nerves. And over distension, so in a lot of organomegaly, it'll force the parietal peritoneum to extend, and then the referred pain can radiate over the shoulder or to the back. And then the mesenteries of the large and small intestines are sensitive to the mechanical stretching only. It's important to note that around the umbilicus is going to be the sensation around that comes from the thoracic 10th nerve. So like T10 is going to innervate that area. Okay, so the circulation goes in a clockwise motion, and it's helped by the movement of the diaphragm. And it's absorbed in the subperitoneal cavities around the peritoneal stomata, and the lymphoids will aggregate. The exudate will move down while the peritoneal fluid kind of just like goes in circles. And this is how the infections occur, because the GI tract and the gallbladder can go downwards due to the colic gutters. In females, of course, there's going to be that uterine tubes that can be infected. Generally happens because of gonorrhea infection in adults and pneumonia bacteria in kids. Another bad thing that can happen is that blood can enter the peritoneal fluid and also circulate, or blood from a ruptured ovarian follicle, and that can cause some peritonitis as well. Okay, so abscesses will generally be in the like the fossa areas, so subphrenic spaces as well, and it will manifest itself as a referred pain over the shoulder. It can be caused by ascites due to the hypertension, congestive heart failure, and Budd-Chiari syndrome. And it's important to note, though, whenever you're trying to drain the abdomen in a paracentesis, you can only drain about 1,000 milliliters a day, and if not, like, you'll kill the patient. Peritoneal dialysis is going to be for people with, of course, some like kidney failure. Is not quite as effective as like the dialysis where you have to have the anastomosis made in the arm in order to, like, filter the blood and whatnot. It's a little bit less effective, but it is less it's less risky, because you're only inserting it into the abdomen and into the peritoneal cavity. There's no surgery necessary. So mesothelioma is not just something that affects the lungs, it can affect the peritoneal cavity as well. And it's caused by asbestos, of course, and it forms all of these like bumps. Like, this is not normal. This should be smooth. Okay, so that's it for now. Thank you for your attention, and good luck studying.